All right, my clock says it's 2:30, so we'll go ahead and get started. I want to do a quick sound check. Everybody can hear me?
We can hear you, Nikki.
Thanks, Director Jeppesen. Okay, thanks for joining us today. My name is Nikki Forbingor, and I'll be moderating the briefing today. Please note that everyone should be muted unless they are speaking. American Sign Language interpretation is available today. If you search for interpreter stubs and hover over the three little dots in the window, you can lock it in place so it's visible on your screen. Today, we're going to hear from Health and Welfare Director Dave Jeppesen, Public Health Administrator Elke Shaw-Tulloch, and State Epidemiologist Dr. Christine Hahn. With that, I'll turn it over to Director Jeppesen.
Welcome, everyone, to our press briefing this afternoon. The data indicates that it is likely that Idaho has reached the peak of this current surge in cases. Testing positivity has declined for the past 4 weeks, and the number of new cases has started to flatten out. And there are encouraging trends in the hospitalization data. However, testing positivity remains very high. The number of cases also remains at very high numbers, and patients in Idaho hospitals remain at all-time high levels. And with that, we'll take a look at our usual hospitalization chart. Thank you, Nikki. As a reminder, this shows the average daily census starting in June last year, and this data is all ages, including adults and children. The latest numbers are as of Saturday, October 16. For this past week, we remained at very high but declining daily average census numbers. You can see we had 615 COVID-19 patients on average in the hospital last week, down from the prior high of 759. We had 176 COVID-19 patients on average in the ICU, down from the previous high of 202, and 108 COVID-19 patients on average on ventilators, down from the prior high of 131. But I want to emphasize again that of the numbers is encouraging, they are still way too high. The number of COVID-19 patients continues to exceed the healthcare resources available. It also means that we all need to continue to do our part. And with that, Nikki, we'll take a look at our vaccination chart. As a reminder, this is data from May 15th, when those over 16 became eligible for the vaccine, to Saturday, October 16th. This is the information on cases, hospitalizations, and ICU stays and deaths from case investigations during that time, and shows how many were vaccinated versus those not fully vaccinated. For reference, 53.9% of those 12 and older in Idaho have been fully vaccinated. As you can see, these numbers remain stable from week to week, with 87% of COVID cases, 90% of Idaho COVID hospitalizations, 92% of Idaho COVID ICU stays, and 86% of COVID deaths are from those not fully vaccinated. Thank you, Nikki, for sharing that chart. As you can see from these numbers, the vaccine is effective, even against the Delta variant. I encourage everyone to consider choosing to get vaccinated. And as I said, we are not out of the woods yet with this current surge in cases. I encourage everyone to wear a mask indoors and outdoors in crowded spaces. Finally, just a reminder that if you need urgent or emergency care, please seek medical care. If you normally would go to an urgent care facility for what you're experiencing, do that. If you need emergency care, go to the emergency room. Hospitals are not turning people away. Please seek urgent or emergency care as needed. The talented healthcare workers in Idaho will work hard to make sure you receive appropriate care. And with that, I will hand it over to Elke.
Right, thank you very much, Director. And while we're seeing a stabilization in cases and hospitalizations overall in the state, which is encouraging, of course, we do want to re-emphasize, or I want to re-emphasize, the Director's comments that we're not out of the woods yet. We have areas of the state where things look very different than the statewide numbers, as well as some population groups on which we're keeping a close eye. When it comes to the percent positivity, as we've discussed in past briefings, the ideal is for our testing percent positivity to be below 5%. Our statewide percent positivity has declined over the last 4 weeks from 17.3% to 13.2%, roughly 1 percentage point per week, but it still is well above the 5% that we look for. Also, we still have counties that are in the 30% range, such as Boundary County at 34.3% and Shoshone at 30.1%. Our district percentages range from 10.6% in Health District 4 to 22.2% in District 1. Also, according to CDC, we continue to have the majority of our counties considered to have high community transmission. We have 41 of Idaho's 44 counties categorized with high community transmission rates. The 3 counties that are not categorized are cluster with substantial community transmission, Camas and Clark, both having low transmission according to the CDC. These counties have very small population bases, so even a few cases can change that categorization, tipping them into substantial or high community transmission. When we compare our deaths in 2020 to the deaths in 2021, we see some striking differences. The majority of deaths in 2020 were among people aged 80 and older, but in 2021, the majority of deaths are among people younger than the age of 80. More specifically, the proportion of deaths among 50 to 79-year-olds has increased, and the deaths in 2021 for people aged 18 to 49 has almost tripled since 2020. Switching to some age populations, when compared with incidence rates during the first week of July, recent incidence among Idahoans aged 5 to 12 years of age and those aged 70 to 79 years of age have been relatively higher than other age groups. However, none of the age groups appear to be increasing recently except for the 70 to 79-year-old age group. And we're very grateful that cases reported among our youngest Idahoans appear to be on a downward trend. The reason that I want to point all of this out today is to help explain our cautious optimism, as I keep using. Our hospitals continue to operate in crisis standards of care. We continue to support them with grants, staffing support, and sometimes even 24/7 logistics, because their strain is still significant. While people in the hospital with suspected or confirmed COVID-19 or in the ICU with confirmed COVID-19 are on a decline, the numbers of people in the hospital is vastly greater than it was during the winter 2020 peak. Hospitals continue to make some very tough decisions, and our healthcare workers continue to see more death and suffering than they should. Additionally, as we continue to say, we're concerned about our youth and the impacts the pandemic is having on their ability to learn in the classroom, as we see schools affected by COVID cases and their students and staff. In the absence of universal masking in K-12 school settings as recommended by CDC, robust testing and mitigation measures, some schools are facing closures, severe staffing shortages, and disrupted learning. The funding we're providing to schools is an opportunity to assist in robust testing and COVID staff support to ensure that the cases are identified swiftly to mitigate the risk of spread. We have 54 schools or school districts that have indicated an interest in the funding that we've made available, and 21 schools have funding en route, and just testing materials have been provided to 13 or more schools. I want to point out that other schools are already doing a lot of this work without the department's funding. And lastly, we have solidified our contract with Vault Testing to secure tests so we can make more test kits available to schools, and those shipments are already starting. So in closing, if we truly want to celebrate an end to COVID and success, we need to increase our vaccination rate. We need to embrace wearing masks to protect ourselves and others much more robustly than we have seen it now. We need to limit our social interactions, and we need to avoid large gatherings. We know it works, we know it saved lives, and we know it's how we can get out of our crisis standards of care and get our kids back to the classroom where they deserve to be. And that, I will turn it over to Dr. Hahn.
Thank you, Elke. I just had 2 areas I wanted to just provide some updates on. One is the vaccines, and the other one is on monoclonal antibodies. So as far as vaccines, I think most of you are aware that last week, the FDA's advisory committee did recommend that FDA authorize Moderna boosters at 6 months or later, and Johnson & Johnson boosters at 2 months or later after the initial dose. And I have not heard yet today, maybe some of you have, but I believe we're expecting FDA to issue those authorizations. I haven't heard that they have, but they're expected to probably today or maybe tomorrow. And the Advisory Committee on Immunization Practices that advises CDC is going to be meeting tomorrow and Thursday. Tomorrow is a non-COVID day. They'll talk about flu and some other vaccines. And then Thursday, they'll be talking about these boosters and recommendations for boosters. So they should come out with a recommendation by the end of Thursday. CDC has been very quick lately about adopting those, endorsing those recommendations, as it were. And after that, those booster shots can start. So I think for folks out there who got Moderna and Johnson & Johnson vaccines, this is good news. One of the things that might be addressed, actually, even in the FDA's authorization language, would be potential mix and match, meaning people who got one type of vaccine for their initial doses, whether it was 2 doses of an mRNA vaccine or a single dose of Johnson & Johnson, that there may be language that would not recommend, but could allow providers to offer a different shot for a booster, for example, if they didn't have what that patient got for their initial series. So we'll see. We're waiting for the FDA's language on that. And the CDC will probably mirror that language. It seems like there's comfort that that is at least safe and produces good antibody responses. So the next big news will be next week on October 26th. Is next week? Yep. October 26th, the FDA will be meeting to discuss the Pfizer vaccine for 5 to 11-year-olds, of course. Pediatric vaccine will be shipped as soon as it's authorized. So even before the CDC has met, they plan on starting the shipment. So and the CDC's advisory committee is expected to make recommendations. They have a meeting coming up November 2nd and 3rd. One of those 2 days will be discussing the Pfizer vaccine for 5 to 11-year-olds. If those recommendations come out, CDC will probably endorse them very quickly, and booster doses, or excuse me, not booster doses, I'm so used to talking about boosters, vaccines for 5 to 11-year-olds will then become available, which will be obviously a great relief to, I know, a lot of parents of children of that age who I think will be very happy to know that those vaccines are available. So if all goes according to plan and what we hope happens once the committees have looked at the data and had discussions, is that vaccination could start as quickly as possible thereafter. Our immunization program was just notified this week that we have an allocation of pediatric vaccine coming to Idaho, and they've been working very hard with the local health departments and other partners to strategize on making sure we get pediatric vaccine, once available, distributed fairly throughout the state to all the 7 public health districts and throughout the state. So stay tuned for more details on that as we work out exactly how many doses will be going to each part of the state. And also some pharmacies will be receiving direct shipments from the federal government as well. So we're very excited about these developments. As far as monoclonal antibodies, I just want to mention that after weeks of mentioning that we're working on it here in the Treasure Valley, we have entered into an agreement with a provider here in the Treasure Valley, Direct COVID Care, which is medical director is Dr. Ryan Williams. We're very excited to have them start work on making monoclonal antibodies more available to the public here. We also had very productive conversations over the past week with another provider that we're hopeful, and hopefully we'll have something very soon about another provider in the Treasure Valley that can serve a little west, more west. Dr. Williams will be operating primarily in the Boise area, and this other partner we're hoping will be able to serve a little more closer to Meridian, maybe Canyon County, out that direction, so that folks in that area have more access, I should say. They do have some access already through some other providers, but we're trying to make that access easier and better. So those are my updates, and I'll turn it back, I think, to Nikki. Yes. Thank you so much.
Yes, thanks, Dr. Hahn and Elke and Director Jeppesen. All right, we'll now go ahead and open it up to media questions. Most of you know the drill, but just please raise your hand in WebEx or type your question into the chat area. And when I say your name, unmute yourself, announce your name and media outlet before you ask your question, and then clear your hand when you're done. So it looks like our first hand was raised today. It was Karen Bosick. Oops. While Karen works on her mute button, I want to point out that we did post a link to the visuals that we showed during Director Jeppesen's comments. Those are available on our website, and there's a link there in the chat if you guys are interested in those. Let's see. All right, we'll move on. I'm not sure what's going on with Karen, but we'll move on to the next person who had her hand up, and that was Melissa Davlin.
I'm sorry, can you come back to me? I have a crying baby.
Oh, sure. All right, our next we'll go to Andrew Bertline.
Yeah, Andrew Bartline, KTVB in Boise. What do we know about COVID breakthrough deaths and the possibility of that? You know, with Colin Powell kind of making national news, there have been people that are citing that as a reason not to be vaccinated. What is the response to that? Especially, what do we know with the data here in Idaho?
Yeah, thanks, Andrew. And I'm not sure if Dr. Hahn or Dr. Turner would be who's the most prepared to answer that. So I'll let you jump in.
Yeah, I'll let Dr. Turner answer it. I think the director addressed it as well with his statistics, either one.
Good morning, everybody, or good afternoon, everybody. So we have had a few deaths among people who have been completely vaccinated, not a large percentage of our deaths. I will just take a moment to let everyone know that the cases of vaccine breakthrough are occurring among, in general, a statistically significantly older population than cases in general. So vaccine breakthrough cases tend to occur in a much older population. They also tend to occur in a population that has certain underlying conditions.
Existing health conditions. Is there sort of like a hierarchy to those? Maybe somebody who's 25 with a lot of pre-existing conditions compared to someone who's 85 and healthy. Do we know, or we can make an educated guess, who's at a higher risk?
Dr. Turner or Dr. Hahn?
Yeah, I'll let Dr. Turner may have some thoughts based on our Idaho data. I can say from the Israel data that it really looks like age is the number one risk factor that's easily identifiable. You know, that said, it's all based on what data you have and what data you can collect. It could be that someone severely immune compromised is at just as high a risk as someone who's 85, let's say. But the strongest data is certainly age-based. I don't know, Kathy, if you have anything to add for that.
Kathy, you're on mute.
I muted myself and then began speaking. You're absolutely right, Dr. Hahn. I'll give you a good example. When we look at not fully vaccinated cases, the mean age is 39.5 years. When we look at fully vaccinated cases, the mean age is 53 years. Age is a really, really big factor. But I will also point out that among the cases that we have information about, which more recently, some of that information is missing, that among those people who are not fully vaccinated, only 7.5% of them have an immunocompromising condition. That percentage is over 40% among people who have a vaccine breakthrough case. So there's confounding with age and underlying conditions, but it's a different population that is getting vaccine breakthrough cases in general. And so that might be contributing to some of the more severe outcomes we're seeing every once in a while in this population.
All right, thank you, Dr. Turner and Dr. Hahn. Melissa Davlin went ahead and typed her question into the chat, so I'll read that aloud here. Melissa Davlin works for Idaho Public Television. Assuming vaccines for children get approval, what sort of messaging is DHW preparing to convince parents to get their children vaccinated? Will there be messaging in Spanish and other languages specific to vaccines for children?
Yes, thank you for the question. And Sarah Leeds, our immunization program manager, is not available for today's briefing, so we will fill in for her. Certainly the department is working with our great communications team to focus on messaging for our pediatric population as a new vaccine becomes available. We are looking at messaging in different languages. We are working with our pediatric provider populations. We know that there are a lot of personal conversations that patients need to have or parents need to have with that pediatrician to help them feel comfortable in making that decision. So we are currently working with our pediatric folks to make sure that they feel comfortable having those conversations. So we are working behind the scenes to get a lot of that prep work done and messaging done so we can get that out the door as quickly as possible. And Dr. Turner, since Sarah's program is within your bureau, if you have anything that you'd like to add, please feel free.
No, Elke, I think you covered everything. Thank you.
Okay, our next question is going to come from Rebecca Boone.
Hi, Rebecca Boone, Associated Press. I'm wondering what the numbers are for that first allocation of pediatric vaccine, and are you anticipating, what kind of demand are you anticipating, and how will that be rolled out? Like, will you identify more at-risk pediatric populations first, or will it just be, do you expect to have enough for everybody who wants it in that first batch to get one?
Yeah, thanks. That's a great question. And Dr. Turner, I can turn it back over to you, or Dr. Hahn.
Yeah, I'm not sure if Dr. Turner's seen the email yet. We just learned this week, and I just got the numbers today. Dr. Turner, I don't know if you had a chance to see them, so I'm happy to let you know, everybody know what we've heard. Sarah Leeds this morning sent out the numbers to us. So we know we have 61,800 doses in that first allocation. And we can start pre-ordering tomorrow, actually, and they will be kind of allocated out in about roughly 20,000 doses per week over the next 3 weeks. So, and absolutely, we've had a lot of good conversations about making sure, I've mentioned already geographic equity, but we also want to make sure that it doesn't just go to the large providers. I can't remember if we mentioned on this briefing before that the dose for at least initially, it'll be a 300 dose minimum order that the feds will ship. And so that, of course, seems like the small provider that has a very small number of children will have a hard time using those doses. So that's where the health districts are stepping up and planning with the immunization program on how they can help redistribute vaccine like they've done in the past to make sure that small providers get it as well. I think I already mentioned that some pharmacies throughout the state, I just earlier today was on a call with CDC and was asking them about this. Unfortunately, we have not been able to get a list. I asked for which pharmacies will be getting the vaccine directly, and they said they don't have that information to give us yet. I think it's just a matter of the speed of which things are moving. But we know some pharmacies in Idaho will also directly receive vaccine in addition to the doses that we're aware of.
As opposed to discharges this decline? Thank you very much.
Thank you for the question, Vinny. Dr. Turner, I don't know if you have that data right at your fingertips.
I do, but I have a million screens open right now. So our peak, I think, Vinny, you asked about peak hospitalizations. We peaked a couple weeks ago at 759. And then the most current week, which is the week ending Saturday the 16th, the average was 615. And then with regard to how many of those patients were discharged versus how many died, we'll have to get back to you on that. We do have the data, but I don't have it pivoted. So.
Let me ask you one other question, if you don't mind. Has there been any new treatment introduced in the hospitals to speed up the number of discharges?
Dr. Hahn, would you like to address that?
Yeah, let me answer the best I can. Talking to, I just recently had a good conversation with Dr. Souza, and certainly we communicate regularly with other doctors that are actively treating COVID patients in the hospital. And they will tell you that they feel they're doing a lot better than they were a year ago. The statistics are hard to, parse through because, as Dr. Turner pointed out, the populations keep changing, who's in the hospital. We have a different variant than we had before, et cetera. But the hospitals have done a lot of things differently. One thing you'll hear over and over again from hospitals is that the whole idea of putting a patient, what they call prone, so instead of, we think of a patient on a ventilator lying on their back, but as you may know, these patients are being turned over during the day and they're spending part of their day on their abdomen. As well as we know there are some treatments, remdesivir, steroids, and other treatments that have been introduced over time. And all of those, the providers feel like they're doing better with treatment. Now, paradoxically, the other thing we've heard from the doctors is because these patients are younger, that they can actually have longer average hospitalizations because the elderly patients would come in and actually they would either make it, they weren't that sick and they would be able to pull through pretty quickly, or they would die quickly because they just were not able to withstand the infection. Now with the younger patients, they are more resilient and they're actually having longer periods of time in the hospital. That's been an interesting phenomenon, and it's kind of counterintuitive at first.
Thank you very much. Have a great day.
Thank you.
Okay, we'll move on to our next question, and that's going to come from Audrey Dutton. Audrey, if you're speaking, you're still on mute.
My question is for Director Jeppesen.
There we go. We heard you that time.
Okay. I am wondering that cases are on a decline and hospitalizations are at a level that they were at prior to going into crisis standards. Can you explain why we're still in crisis standards of care in our hospitals around the state?
Thanks, Audrey. Director?
Yeah, that's a great question, Audrey. The short answer is the number of patients in hospitals, particularly up north and here in the Treasure Valley, is actually higher than when we went into crisis standards of care. What we're really looking for is those boxes that were checked that said, yep, it's time to go into crisis standards of care, that they get unchecked coming out. So I'll give you an example. When we went into crisis standards of care, one of the factors was space. We were seeing patients that were being housed and treated in non-traditional space areas of the hospital. Up north in Kootenai, it was a classroom. Down here in the Treasure Valley, they've converted day surgery units into patient care units. So we would be looking for some of those things to go back to within the normal footprint of the hospital, just like they were before we declared crisis standards of care. Another one we'd be looking for is many of what they call yellow surgeries have been postponed. In fact, almost all yellow surgeries. I have to have a professional explain what that means, but it's surgeries that are not just that have some level of urgency, but not a high level of urgency about them. Those have been stopped, and we would be looking for those to be started at some level before we come out of crisis standards of care. And then one further example on the staffing side is right now the hospitals are running even with all the extra staff that have been provided through our federal partners and the National Guard, are still running at higher ratios of staff to nursing than they would under the normal standard of care, the usual standard of care. So those same criteria that we looked at that moved us into crisis standards of care will be the ones we look at to move us out. It may or may not be tied directly to the number of patients, because it's a combination of number of patients, the acuity level of those patients, and the staffing levels that are available to take care of those patients. And so we'll look at all of those factors. We, as we've mentioned on this call before, we have a daily call with the hospitals, which gives us a really good insight into how things are going, as well as some weekly higher level calls to really understand what the situation is. So we watch closely. Believe us, all of us in the healthcare industry want to get out of crisis standards of care, and we're watching those criteria very closely.
Thanks, Director Jeppesen. Our next question is going to come from Blake Jones.
Hey, thanks, Nikki. Yeah, my name is Blake Jones from Idaho Education News. My question is related to the money allocated to schools for coronavirus screening programs. I'm wondering if in your communications with school districts, if you're suggesting that schools set up their screening programs in one way or another. I know I heard a couple of you speak to West Ada last week about the benefits of surveillance testing programs, and I'm wondering if there's kind of a systematic approach that you all are suggesting across the state.
Thanks, Blake. I'll start and then turn it over to Dr. Turner. The funding that we're making available to the schools is really for them to use at their discretion. For sure, we are providing, consultation, guidance if they're asking about that. So, and certainly the local public health districts are doing the same. But it's really up to the individual schools themselves how they want to establish that, if they want to do that work themselves, if they want to hire a contractor to come in and do that work. So physically how they manage that is really of their own making. But I'll let Dr. Turner wrap up any further comments.
Yeah, it's a good question, and I want to reiterate what Elke stated, and that is that we're working with them to make sure that it works for them. It works for their community. You might have a very small rural school that, has 100 students, and then you might have, somewhere like around here, like, Boise High, that's got hundreds of students, and one size is not going to fit all. And we have some schools who are interested in diagnostic testing only, some schools who want to implement a screening program. And so the funding is not just for screening programs. It is also can be used to help them fund contact tracing. It can help them with, paying for additional staff for, mitigation measures, implementing mitigation measures. It's not just for testing. It's for COVID-19 prevention and control from start to finish. So I wanted to reiterate that we're not limiting the funding just to testing.
Okay, we'll move on to our next question, and that's going to come from Joe Paris.
It's Joe Paris with KTVB in Boise. Kind of building off what Audrey Dutton had asked, I'm curious if there's a timeline of when crisis standards of care could be ended. I know what you just described. A very common question we get is, are we talking about weeks or months in terms of getting into those yellow surgeries? And then my second question would be, speaking in general terms statewide, is the state of Idaho better, worse, or the same in terms of the COVID situation as I guess 1 month later, or a little more than a month later, when crisis standards of care were declared? Thanks.
Great, thanks, Joe. Great questions. And Director, would you like to kick that off?
Yes, as long as I hit the right button and don't turn my camera off and instead open my mute up. I think, Joe, your question's a good one, and it's very similar to Audrey's question. And I'll start with the last part, which is, are we better off, worse, or the same when we declared crisis standards of care? In a lot of ways, we're still in a worse situation than we were when we first declared crisis standards of care. We still see very high patient loads, many situations higher than when we declared crisis standards of care. We have added in more staff that have helped out a great deal. And that's been through both the hiring that hospitals have done, as well as the staffing that have come in from our federal partners and through our DoD partners, et cetera. And what I will say is that the hospitals have done an incredible job of converting spaces, of being creative of how they make sure they get all those patients taken care of. And that has actually created stretching nursing ratios, et cetera. And that has created the ability to manage the situation the best we can. But I do not think that we are back to the place where we were when we first entered crisis standards of care. We have a little ways to go to kind of get back to that place. And then as far as a timeline, that's not something we're going to set as a timeline. There's no, we have to get out of crisis standards of care by X date. That's really going to be driven by the situation on the ground. And so that's why we continue to watch every day. We hope it's soon. We know all of our healthcare partners hope it is very soon. The public hopes it's soon. We all hope it's very soon, but it'll be driven by the situation on the ground, which is really a factor of how many cases do we have, what's the staffing situation look like, and are we able to get back to the usual standard of care given our current situation. So it's a little more fluid. One of the things I've learned through crisis standards of care is I thought it would be a little more black and white than it turns out to be. It's actually got some fluidity to it as the situation changes every day. And we will continue to watch it every day and strive to do the best we can to come out of crisis standards of care. And we will just continue to ask the public to do what to help us out. And the best way they can help out is continue to get vaccinated and continue to wear masks. Is the best way they can help accelerate us getting out of crisis standards of care.
Okay, thank you, Director. Our next question is going to come from Ian Stevenson.
Thanks. This is Ian from the Idaho Statesman. I was hoping for a bit more information about the status of the case backlog. On the dashboard at the moment, it says there are around 4,400 cases currently pending review or follow-up by local public health districts. I was wondering if it's known from when those cases date to, like what the oldest ones are, and also whether each day when you all update the dashboard, are the bulk of those cases being added cases that were reported that day, or are most of them now cases that were added on previous days?
Great, thanks, Ian. And this is certainly a question for Dr. Turner, who is managing all of that. We are making some progress, but Kathy, if you want to elaborate, that would be great.
Yeah, thanks. So Ian, some of your questions a little bit on the weedy side, so I may not have the best answer for you right now. But they're making significant progress on those cases. I will tell you that the term backlog might be a misnomer because most of them have been received within the last 7 days. But when you get, 1,200 a day, it's pretty hard to work through them. So what I will tell you is that for the most part, those 4,900 observations are from the most recent 7 to 10 days. So as they are working through those, we're updating the case counts daily. But when you look at our dashboard, we have not only the daily number of cases curve, but we also have the 7-day moving average and other measures that kind of update backwards. So, but most of them are recent. They're within the last 1 to 2 weeks. So we're not talking about cases from like August or September.
And are some of those, just a quick follow-up, are some of those, so when you update it each day, some of those were reported that day and others are from the previous 7 to 10 days?
Yeah, correct. So obviously they're going to work on the most recent to try to get those people contacted and provide public health recommendations and intervention. But they're also chipping away, at cases that might be, a few more days old. So it's a combination. And I can't tell you the proportion because it varies by day and it varies by public health district.
Okay, thanks.
Okay, our next question is in the chat, and it's going to come from Morgan White from BYU Idaho Radio. She wants to know, do we know which Idaho regions are experiencing the highest strain on healthcare systems because of COVID cases? And then what sort of factors contribute to the strain these regions are facing?
Yeah, I can take that question. And so I alluded to, well, I talked about it in the beginning in my opening remarks about certain areas of the state that are experiencing higher positivity rates, which almost directly translate into higher strains on healthcare systems. So as I mentioned, the 2 counties in North Idaho that have percent positivity rates at 30% or higher, we know for sure, as the director said, we meet with the hospitals every single day and on a weekly basis. And certainly all the hospitals in the northern part of the state are feeling significant strain. And so you can really just go through the data that we have on our website and see where those percent positivities are higher, where cases are higher, and you can almost directly translate that into higher strains in the healthcare system.
Okay, thanks, Elke. Our next question is going to come from Elizabeth Hadley.
Okay, great, thank you. My question is, I feel like in the beginning when the vaccine came out, it was really hard for people that wanted to get the vaccine, to get the vaccine. Like, we were getting a lot of questions here. Like, I go on to try to make an appointment and they're already all full. And I feel like that was because we just there weren't enough, doses here in the state yet. But then I feel like now people are so like adamant. Everybody that is like gonna get the vaccine has like gotten it, and now they're probably like getting their booster shots. And like, I feel as though here, especially in like the Magic Valley where I am, there's so many people that are so adamantly against it. Like, are we still seeing a lot of people getting the vaccine, or is it kind of like a slow, steady trickle of people getting the vaccine, or is it a lot? Maybe just here where I am in Twin Falls, people are just against it.
Yeah, great comments, Elizabeth. We certainly have seen a decline in the initial dosing of people, vaccines for people, but we certainly are seeing an uptake in the number of booster doses across the state. But you're correct in your observations that it certainly is not the same fervor for getting the vaccine that we saw in the early stages of the pandemic, especially when vaccine was very limited, and now we have a good supply of vaccine in the state. And there are certainly populations that still do not feel comfortable or may never get vaccinated, but we hope that over time people will see the significant progress that we're making with preventing hospitalizations, serious illness, and death in those folks who are choosing to get the vaccine. It's a really important tool in everybody's tool chest to make sure that we can stay safe. That's, again, as we say every single week, this is why we're having these press briefings, is to work through some of those things. And we want to be able to train local healthcare providers as well and other trusted partners to have those conversations with people that have been more comfortable getting the vaccine, because it is so effective and safe and important. But we certainly are seeing that some of that decline in the uptake of the vaccine. Kathy, I don't know if you had any, or Dr. Hahn, if you had anything you want to add.
I think the only thing, Elke, that I will add is to quantify it is that, we're still getting around, on average for the last 60 days, about 1,500 people are choosing to go in and get their first dose every day. So that's not bad. Every single one of those people is a reason to celebrate. So it may not seem like a lot, but 1,500 people a day choosing to do something is a big deal.
Great point. Thank you.
Okay, I think we're going to move into a round of second questions here. So we'll start with Audrey Dutton. Hi, Audrey. We can't hear you.
My question is for Dr. Hahn. So I figured it out. I have to unmute myself on my phone as well as on my computer. The question is for Dr. Hahn. Based on what you know right now, what we know right now, when you imagine life 3 years from now, what changes do you think we might see in Idaho healthcare and in the overall health of Idahoans?
Dr. Hahn, you're muted.
Yeah, thank you. Sorry. Yeah, I actually love these kinds of questions in a way. Of course, we don't know. But the kinds of things that I think we think about are, I'll start with some of the healthcare delivery things. I think we all believe telehealth is here to stay. We don't know exactly what it'll look like, how much of what's currently being done by telehealth might go back to in-person, but I think that some of it will stay. It's been generally considered very successful, and certainly is a really great thing for people living in more and I wonder if some of us will be more open to doing that during flu season or sometimes, or maybe we have a little bit of a sniffle putting a mask on. So I think that culture might have changed because of people getting used to that and seeing the benefit of that. I think the other thing, of course, we think about is kind of like flu. Will we be getting regular COVID boosters? I think very few, like I think we talked about last week, very few of us think that COVID will disappear. It is more likely at this point to turn into something where we either kind of like flu, get an annual booster, or possibly like tetanus, we get something every 10 years, or maybe we'll discover that like measles or some of the other vaccines that most people only get once or twice in their childhood and then never have to get vaccinated again. Maybe we'll find we don't need more vaccines, but I think there's kind of just a whole realm of possibilities to think about. I've seen lots of interesting articles, I'm sure many of you have, on some of the profound changes to society that this pandemic is, think about travel, the impacts on travel, and those kinds of things that we can't even begin to think about. Those are a few that leap to mind.
Okay, our next question is going to come from Rebecca Boone.
Hi, Rebecca Boone, Associated Press. I'm wondering if parents of children who qualify as immune compromised, if that criteria will be the same for kids as the criteria for adults, and if they need to talk to their doctor about taking any steps before.
Missing something that you're driving at, and I just want to make sure I understand it.
Thanks. I was just mainly wondering for the 5 to 12 set that's going to be coming up, if they'll need to get a third dose and if they'll need to talk to their doctor about stopping immune compromising medications or changing dosing schedules, things like that.
Great. Thank you, Rebecca. That's actually a great question. I think it is likely that the advisory committee on Thursday will discuss that, whether that recommendation for a third dose will go down. As we know, sometimes younger kids have a stronger immune response to some vaccines than adults, than older children even, or adults. So it is possible that the decision will be made that this isn't necessary in that age group, or it might be that there'll be discussion that yes, they too should get 3 doses. So we'll see where the committee lands on Thursday. I haven't heard anything yet that would give me intel on which way that might go.
Okay, thanks, Dr. Hahn. Our next question is going to come from Melissa Davlin.
Thanks, Nikki. I think this question is for Director Jeppesen. After a month and a half of crisis standards of care in North Idaho and a month here. Yeah, I think this expands on Joe's question a little bit earlier. Are there any lessons learned or anything that you would want to tweak about the plan if, heaven forbid, we have to enter crisis standards again in the future, knowing that it's likely COVID won't go away?
Director.
Well, thanks, Melissa. I appreciate that question a great deal. So first, I just have to say, I really hope we are never have to go back into crisis standards of care again. So that would be the first and foremost best plan that we could have. It's not a pleasant, it's a measure of last resort and not a pleasant place to be. There certainly have been a number of lessons learned as we've gone through crisis standards of care. And but generally speaking, I think our processes have been well carried out and served us quite well. And we've mentioned a couple on this call and previous calls as well, which is our ability to coordinate resources statewide, our ability to understand the situation daily, even hourly statewide, is actually quite robust. And that's actually been a real blessing to us through this crisis standards of care phase. And frankly, has saved lives because we've been able to move resources and patients around to where they can get the treatment that's needed. But some of the things that we have learned is that it's not nearly as black and white as we thought it was going to be. It's not nearly as definitive as we thought it was going to be. As I've described earlier, it's very fluid, changes hourly, and it changes between critical access hospitals and main tertiary hospitals, et cetera. And I think that's one of our lessons learned. And then I think some of the other lessons learned that we've carried out that we'll tweak as we look forward, again, hoping that we never have to go back into crisis standards of care, is continuing to get better and better about moving patients out of the hospital that are no longer need to be there. And so we've had for many years in the state challenges with moving behavioral health patients out to appropriate behavioral health settings. And through the pandemic, moving patients out that are ready to go back to a long-term care facility, but making sure that we have a place for them to go at a long-term care facility, I think has been one of our bigger lessons learned as to how do we do that better if we were ever here again. So there's a couple quick thoughts on what we think we've done well and some things we could do different next time if we ever again, hope we never do, but if we ever have to come back to this state.
Thanks, Director Jeppesen. I wanted to point out Dr. Hahn put a note in the chat, and for those of you who may not have access to the chat, she said, I just realized I should have said that ACIP, the CDC committee, will talk about this in their November 2nd to 3rd meeting when 5 to 11-year-old vaccination is discussed rather than this week. So I think there's a set of ACIP meetings this week where they'll be discussing something else. So wanted to make sure everybody was clear on the timing of that. And with that, we'll take our next question from Ian Stevenson.
Thanks, Ian from the Statesman. I had a question about the school testing funding that's being distributed. If I've been understanding you all correctly, I believe you've been saying for a few weeks that the funding is en route to various schools and school districts. I wondered has any of that funding arrived at schools or school districts? And if not, is there a reason for that? And is there a timeline for when that funding may be received?
Yeah, thanks, Ian. Dr. Turner can address this more specifically, but certainly subgrants have been signed with some of the schools to date, which then allows for that flow of resources. But in terms of the numbers of schools, I don't know if Kathy, you can give a better estimate of exactly where the money is in transition.
Yeah, so it depends. I always seem to say it depends. Sorry about that, Ian. But we have executed 14 subgrants so far for a total of almost $5 million. So what that does is it gives us an instrument of, sort of agreement that the school's going to do X and we're going to give them so much money. And so the instruments are in place now. Not all of them have been completely signed by both parties, but they are agreed upon, they're in place. And then the schools will request that funding as they need. It's not like we're giving them, sort of a bank account with all the money in it. They will essentially draw down the funds that they need in order to implement their programs.
Okay, thanks.
Sure.
Okay, I wanted to circle back and check in with Karen Bosick to see if she's had her hand up. I have not had anything in the chat, but I wanted to give her an opportunity. Looks like that may be a mistake, or maybe she's having technical difficulties. So looks like that is our last question for today. So we'll go ahead and wrap it up a couple minutes early. We are planning another media briefing at 2:30 p.m. Mountain Time on October 26th. So this concludes our briefing today, and we'll see you next week. Thanks.